Good morning. I just want to speak about coronary bifurcation intervention this morning. So, for anatomical reasons and due to the distributed function of the coronary tree, bifurcation sites are prone to development of atherosclerotic lesions as a result of flow turbulence generating pro-atherogenic low-wall shear stress. And for these reasons, these lesions account for up to 30% in patients with multivessel disease. So the challenge posed by bifurcation disease in the early years of PCI with plain old balloon angioplasty, and many techniques were developed in order to improve the procedure success and long-term outcome. So over the past 20 years, since the advent of the drug-eluting stent, bifurcations have been the subject of intense discussion and debates, and there's been new definitions, new classifications, measurements, imaging methods, as well as various clinical series, registries, and random studies and meta-analysis. So the purpose of this presentation is to examine the strategies currently implemented in the treatment of coronary bifurcation disease, to highlight the most debated issues, and to propose recommendations for an optimal approach. So we start with some definitions. So it's defined by three reference diameters, which is the main branch, proximal and distal, and side branch. The type of bifurcation, the most common classification is the Medina classification, or revised Medina, and it's defined by the percentage stenosis of these three segments. So over 50% is classified as 1, and less than 50% is classified as 0. The most complex lesion being 1, 1, 1. So I'll come back with a schematic diagram of these in a couple of slides down. We'll talk a little bit. So there's a poor correlation between percentage stenosis of the side branch ostium and functional evaluation. Side branch lesions are frequently overestimated by coronary angiogram. So just to brush up on the physics side of things, there's Murray's law, and then more recently Finnett's law, which is the mother is the sum of the first and two daughters by 0.678. And the practical implication of this anatomical functional structures is firstly, there's no linear decrease from the proximal to distal diameter of the coronary artery, meaning the diameter is constant between the bifurcation and then diminishes abruptly when the artery branches into a bifurcation. So this makes all undedicated QCA software and methods obsolete, especially for the analysis of the vicinity of bifurcations. Secondly, coronary bifurcation is not composed simply of a main vessel and a side branch. It has three segments with three diameters and flow: proximal main vessel, distal main, and the side branch. So following the length flow diameter relationship, the DMV should be largest and or longest segment. So that's just to illustrate the Medina classification, which I brushed up early on. So little schematic diagram defining the various types of lesions with regard to the bifurcation. So lately has been the use of quantitative angiography of bifurcation lesions, such as dedicated software. There's physiological analysis such as pressure wire, and there's intraluminal imaging like OCT and IVUS. It's not FFR, it's meant to say IVUS. So just to brush up a little bit on the technique, do we need to define a kissing balloon after one stent technique? So the Nordic 3 study did not show any clinical difference between the two groups at 6 months. At 8 months, follow-up Andrew showed differences in the rate of restenosis between the two techniques in favor of final kissing balloon with a binary restenosis rate in the functional lesion of 11% versus 17.3%. On the other hand, the Kobe study had shown that final kissing balloon was associated with a higher MACE rate as well as the cross and small strategy, while Kobe's 2 showed a significant reduction in TVR and MACE after final kissing balloon. Today, with the available data, it is still very difficult to conclude the optimal technique because many of the other variables may play an important role in the outcome. A new promising alternative is the current evaluated pot side pot technique, or repot. So what strategy to use? Crush, culotte, stenting. So an attempt at identifying the optimal complex technique when needed was made in the Nordic 2 trial, comparing the classical crush to the culotte technique. The culotte technique was used was a straight culotte, which is starting the stent placement in the main branch rather than the side branch. And MACE rates at 6 months were similar, 4.3 versus 3.7%. At 8 months, angiographic follow-up showed in-stent restenosis was lower following culotte stenting compared to crush stenting. And we can speculate that when the bifurcation angle is T-shaped, the 2 stents are needed, and T-stenting technique is probably the best technique. When the bifurcation angle is Y-shaped, then culotte stenting is probably the most appropriate than a classical crush technique. However, the recent data from the DK Crush 2 study have shown a high rate of final kissing balloon and excellent clinical outcome with this technique, and therefore we need more evaluation. If the side branch ostium is not covered by the MB stent, then the tap or culotte is recommended. When the 2 stent strategy is used, final kissing balloon is strongly recommended. So that's just a little schematic diagram of the MADS approach. So main proximal first, MADS stands for main across side first, and D is double proximal lumen, and S stands for the side branch. And there's various techniques that falls into these different categories. And finally, we just want to touch upon complex versus provisional approach. So the risk of stent thrombosis after treatment of bifurcation lesions seems to be more related to the implementation of a complex approach rather than the bifurcation itself. Randomized studies have shown no advantages to systemic 2 stent technique as compared to provisional side branch stenting approach. The complex strategy was associated with longer procedural time, longer X-ray exposure, higher volume of contrast, and increased biomarker evaluation. And to date, the clinical advantage of final kissing balloon associated with a single stent technique has not yet been demonstrated. When a 2 stent technique is used, final kissing balloon is highly recommended. And provisional side branch stenting, which is A approach, is now the gold standard, and it can be used in the majority of cases. And in order to avoid carinal shift, the size of the main branch should be selected according to distal main branch reference. POT is highly recommended in order to oppose the main branch stent proximal to the carina. And when performing kissing balloon, the diameter of the balloon should be selected according to the distal main branch and side branch references. Simultaneous kissing stent technique is not recommended, except in bailout situations. And the crush technique or culotte technique should be avoided in T-shaped angulated bifurcation lesions. And when using the crush technique, a double kissing mini crush technique is the favored approach. So I'm just going to present a couple of cases that we have done recently. So the first case is a 47-year-old chap who's having atypical chest pain, arm pain twice. He's very concerned about his family history. His dad passed away at age 50, he's an MI, and his mom has just recently died of postulated sudden cardiac death after experiencing acute chest pain. So there was nothing remarkable in his ECG. Troponin was negative, and echo did not show any regional wall motion abnormality. So given the family history, we decided to go for a CT coronary angio upfront rather than doing the conventional exercise stress test. And the CTCA revealed 3 vessel disease, so obviously we followed up with a coronary angio. So this picture of the right, where you can see a tight proximal lesion. And that's a cranial view. You can appreciate there's a moderate severe diffuse proximal LED. And that's the caudal view. And you'll appreciate there's a bifurcation lesion. You see it a bit clearer. I'll just try and stop it. I personally think it's Medina 111. You could argue it's 011. I think it's a 111. So the findings were explained and discussed with the patient, and the decision was to proceed with multi-vessel stage PCI. So we're going to quickly brush up on what we did with the right-hand LED and then focus on the bifurcation lesion. So the right was stented across the way, covering from like normal to normal, and it was a 3.5/28 stent, and that's the final result now. So then we tackled the LED, and not really ostial, but very proximal LED. And again, it was a big stent, 3.5/38, 3.5/32. So that's it here, and that's post-stenting. And this is a caudal shot of things. So there we did a stage PCI to the left circumflex and the OM1. So we did a quick relook angio just to check on the state of things, and you see RCA stent is widely patent, as is the LED stent. So then we proceeded to the bifurcation stenting. So these, the OM1 and the circ are both wired with cyan blue wires, and it is sequel predilatation of the lesions using a 2O semi-compliant balloon. So that's the OM1 here, and then obviously with the picture of the circumflex being dilated. So then the main branch, the technique used is going to be a tap technique. The reason I opted for a tap technique is angulation. You can see it's fairly 90 degrees. And the second thing is the side branch is fairly discrepant. It's fairly small compared to the main circumflex. So culotte wouldn't be very practical here because of the size discrepancy. So the first stent that was deployed was 3.28 stent. That's the stent deployment here. And this is just to check, and you can clearly see how pinched the ostium of the OM1 is post-stenting. So that's a bit of proximal optimization technique. So you have to make sure that when you're potting, you're not going beyond the bifurcation, because then it doesn't respect the diameters. So that was potted to 3.5. Back to it. And then wires were exchanged and recrossed, so using the same cyan blue wires. So then what I did, I opened up the struts with a 1.5 balloon, kind of facilitate the passage of the second stent. But as you see, unfortunately, that wasn't enough, because you can clearly see the second stent wouldn't go. So then what I did was to switch to a 2O balloon and make the aperture a bit bigger. And then eventually, that's the second stent here. We can clearly see it just should be inside, just barely protruding. That's hence the name tap with slight protrusion. So first stent is here. I mean, the marker should be just at the tip of the stent. And that's the second stent going up. And final kissing, we're using a 3.5 balloon, the same 3.5 we used. It was parked in the artery. And that's the final result. So I'm going to present the second case. This second guy, 44-year-old chap, atypical chest pain, normal echo, had a treadmill test in South Africa 8 months ago and it was normal. Again, there's extensive family history of coronary artery disease, so went straight for a CTCA and showed 2 vessel disease. He's a smoker and his dad passed away in his 50s, so he was listed for cardiac catheterization. So this picture of the right, as you can see, it's a fairly large vessel and it has moderate to severe disease in the proximal segment. And as you'd appreciate, we've no resort to pressure YOFFR here, so it has to be clinical judgment. So couldn't engage the left with a conventional Judkins left, so we switched over to I think it's an XP3. And there is aneurysmal disease in that. I'm going to come back, sorry. High OM or intermediate, whatever you choose to call it. Here. But other than that, there's nothing much in the circumflex. So coming to the LED, then you clearly see there's a tight eccentric flap up there. And again, long lesion of the diagonal, so a bifurcation lesion, and a distal lesion as well here, and then it's diffuse disease further down. So So the right was tackled first. There was a fair bit of trouble getting the Judkins side would sit, so that's an AL 0.75, and then was able to wire stented. So it's going to go for big stent, so a bit of predilation. We didn't have any large stents, so we took a 3.5/28, 3.5/33 Zions and upsized it to 5. So that's the stent deployment. And that's post-dilation of 5.0. It's not quite osteal stenting, but very close to the ostium. So then decided to tackle the LED in the diagonal. So the distal LED was pre-dilated and stented with 2.5/16 synergy stent. And there's a fair bit of distal disease. I'm not going to touch because there's no landing zone. It's not realistic to be chasing apical and distal lesions like that. So then the bifurcation was tackled. So in the main LED, it's a BMW universal tube, and in the diagonal, it's a Sion wire, not Sion blue, Sion. So that's a bit of predilation. Both lesions were predilated. I think it was a 1.5 balloon initially. And then the main LED was stented, and the stent length was a 3.38 synergy. So again, in this case, because of angle and, well, not quite angle, but size discrepancy, opted for the tap technique. So that's the stent being deployed. Sorry. Yeah, that's the stent being deployed here. So this is the actual deployment. The caudal view, just to make sure you're not impinging to your left main. And that's post-stenting the main branch. So this is the POTS thing, which is talk about proximal optimization. So we optimized to 3.5. And then the wires were exchanged again. And this time I took a field XTA, went through the stent strut and then came back and managed to wire the diagonal. And then the jail wire was removed, JLC on wire. The next thing is we opened up the strut to a 1.5 balloon again. And then I parked the 3.5 non-compliant balloon and advanced the stent. Stent in this case was a 225-24 synergy. And again, positioning for chap, being a little bit outside, it was retracted a little bit just to bring the marker just inside. The stent was then deployed, and we did a kissing balloon with a 3.5 and the stent balloon, and a little bit of POTS afterwards. And that's the final result. So that's pre and post a static shot. And that's about it.